oncologist who has completed quite a lot of training. She's done an MD PhD in Switzerland and 4 fellowships.
Yeah, that's the Swiss way of doing things. You know, we are always a little bit obsessional, compulsive.
Internal medicine, oncology, hematology, and Geri-Onc.
Right.
And the Geriatric Oncology Fellowship was in Tampa, where she is now from. She's an associate professor of oncology and medicine at University of South Florida in Tampa, soon to be the host of our Super Bowl.
Yes.
Number, but next weekend. Yep. She has over 50 peer-reviewed publications and close to 100 publications in total. And her interest is in assessing cancer patients with comorbid disease, medical complexity in cancer patients, and combining geriatric assessment with decision-making for cancer treatment. Is that right?
That's right.
Okay.
You're good.
And we are very pleased to have her today, and she's going to be talking about frailty in geriatric oncology, assessing the elderly with cancer.
Right. Okay. That's the short version. And yeah, frailty, I mean, is always a big question, both in geriatrics and in oncology. And so I thought it would be productive to tell you a little bit the oncology approach to the question and get your geriatric feedback as to what we do right or not. And that will be a little bit. So first, I think we need to ask the first question: are frail patients seen by oncologists? Because you may make an assumption that frail patient is something you find in nursing homes or close to it, and they never make it to an oncologist. So we need first to make sure we speak of the same population. I will define a few terms as far as frailty is concerned, so that we all speak on the same basis. And then we will see how we try to adapt geriatric definitions to cancer care as far as frailty is concerned. Then we'll look at how to integrate frailty in cancer studies. And finally, I'm going to ask what I think is the challenging question that many geriatricians don't realize. Can geriatric intervention change the outcome of a cancer patient? There are some interesting data there. So frailty, here is an example, artistic view of frailty by Gilles Barbier. He's actually an American, but I took that from a Swiss journal. And let's see if frail patients are seen by oncologists. So as you probably know, cancer is a disease actually of the older person. And the median age for any cancer is 67 in the US. And you can see that for many cancers like bladder cancer, colorectal cancer, stomach, pancreas, lung, all that, the median age is way in the 70s. So most of cancers are going to happen in a geriatric population. This is definitely what the epidemiology tells us. Unfortunately, what we see is that, okay, for example, breast cancer, half of them happen above the age of 65, and a quarter of them above the age of 75. But the number that goes into studies is absolutely dismal. It's 4% of study patients above 75 years old. So we have half of the cancer population, and it's basically very poorly studied. So the data we have on treatment of cancer in the elderly from large randomized trials is usually applicable to a minority of older patients. Okay. Studies that have looked at the profile of older cancer patients in different settings. So for example, Flood, that's from Washington in a geriatric inpatient unit, OARS for cancer patients. dedicated to cancer patients in acute care unit. And you can see that indeed they have a lot of cognitive impairments, 50% of them. Depression, they did not check, they have 25% of depression. 70+% of them are dependent in IADL, 50% in ADL. They didn't do the ECOG. On the other hand, you can see that if you look at an outpatient service, like a studies by Retorna in Canada at McGill, and you can see that outpatient geriatric people, you still have a large proportion, that's the dark gray bar, that is indeed dependent in ADL and IADL. Then you go to cancer randomized trial, that's my own. It's a large Italian lung cancer study. And you can see that in that study, actually, you also have a large level of impairment in IADL. That's fairly comparable to that of the geriatric populations, but the dependence in basic ADL is much lower. So here is where the differential happens in a cancer population and the inpatient or geriatric clinic consultation is the dependence in basic activities of daily living seems to be lower, but IADLs is pretty much the same level. Ingram is a VA population in North Carolina. This is Duke, actually. And you can see that for some reason, these VA patients are very dependent in basic activities of daily living. I'm not really sure why. This is an oddball that I can't explain. Because these are outpatients, but visibly they are high prevalence. And then the two last series are geriatric oncology programs. So here you can see that again, we have a level of IADL that is very comparable to the geriatric population, but the level of basic dependence is lower. Depression, there is a significant impairment. Cognitive is a significant impairment. ECOG-PS, this is the oncology performance status. And basically, oncologists tend to consider that 0 is totally independent, 1 is some difficulty in activities, but able of normal activity, 2 is limited, but active more than half of the day, 3 is active less than half of the day, and 4 is bedridden. So I think here it gives us why we may have the impression that oncologists see very healthy patients. Because if you only look at ECOG performance status, despite all these dependence in ADL, IADLs, these patients are qualified as ECOG 0 or 1 80% of the time.
But I thought the ECOG used the ADL.
No,
it's a different.
It's a different. It says in quotes, able of self-care but limited in activity to the daily living, which it says in a very general sense.
The
right.
lower the score on ECOG, the better the performance, right?
Right, that's correct. That's
so
it's in the.
You can get a lower score on ECOG, but still be basically what we would consider dependent.
Right,
yeah.
That is correct. Because
people
it's
have presented for care, but not necessarily didn't necessarily get chemotherapeutic.
Absolutely, these are just patients showing up in the clinic for their first visit. Yeah. So, but I think what is very striking here is for a same setting of clinics, you can go in any country, you have about the same profile. And yes, patients are sicker in geriatric wards, but not as much as we would think. And so I think it's important to see that indeed cancer oncologists do see patients with geriatric disabilities. Here is another example of that. We did a pilot study and we basically were trying to see if reevaluating people every 3 months by the team would assess problems and allow us to address them. We wanted to do that as a pilot for a randomized study. We got the money for the pilot, not for the randomized study. But basically, the whole team was seeing them every 3 months, monthly phone call by nurse practitioner, and the other contacts according to their risk in their various domains. It was a small group. We have 11 patients evaluable on 15. 6 were at high pharmacological risk, 3 moderate, 1 low, 2 moderate social risk, 1 low. Dietary, of course, breast cancer patients are not at particular dietary risk, so we are not expecting to be very high. But what is absolutely striking is the adjuvant breast cancer setting is considered it's like the no problem population in oncology. And despite that being a no problem population, they had 6 initial problems detected and 3 over the next 6 months. So really the geriatric assessment did detect a bunch of problems in these patients. And I think that's a very telling point that cancer patients have problems. And not only do they have problems, but we had interventions. We had actually 184 recommendation interventions, so that's an average of 17 per patient for these cancer patients. Multidisciplinary for about 1/3 of the cases. And pharmacy was also very involved. Examples of these interventions. Well, the CGA did modify the chemotherapy decision in an 83-year-old patient who had memory problems. However, when we analyzed the memory problems, it seems that they were very focused. But then there were all sorts of things. Finally, we gave her chemo, and the memory was not a problem. Her appetite became the problem. We detected a wrong filling of a Paxil prescription for QID instead of QD. The patient was not feeling very well. Yeah. We increased compliance with hormonal therapy in 2 patients, 1 on study. So we improved the compliance with the cancer study. And also we did a family council to control medications of a patient who was stashing all sorts of stuff. And she improved her MMS.
Mean age about?
It was 79 in that series, yeah, median.
Not all these people got chemotherapy.
Only one, actually. Only the top one. All the others got simply hormonal therapy. So you would not expect to see a lot of problems in these patients.
Breast cancer patients.
Yes, we were obliged to focus on adjuvant breast cancer patients by the NIH reviewers. You know, it's one of these things. You say, oh no, you shouldn't address too many cancers. You should focus on one, and so dutifully do what the reviewers ask you to do.
They were all negative, or they were.
No, so no, a bunch were not positive. I don't remember how many, just right now. Yeah, they were limited stage, but they were, yeah. Okay, so that's in Oslo, if you park with things. So, what is the definition of frailty? So this is how I understand what geriatricians think is a frail person. It's someone with a minimal functional reserve who is at high risk of dependence and death in the near future. Okay. In other words, it is a prognostic definition, very much. And an example of that is the frail, the Fried criteria, which I think in a working conference at the NIH decided let's take tentatively that into studies and try, but I mean, if we find better, we'll change, kind of, sort of, right, basically, that's what they said. So, because personally I have a hard time of identifying what 383 kilocalories per week is as an activity, but, okay.
Not very clinically applicable.
Right, indeed, indeed, it's a challenge in the clinic. But anyway, that's one way of defining it. Now, how is it for the oncologist? Well, for the oncologist, it's basically a patient who is a poor functional reserve at high risk of getting into trouble if I do anything aggressive with them. Okay, that's how we define a frail patient. So it's an operational definition, actually, of frailty, much less a prognostic one, because usually we worry about the prognosis of the cancer. We may be wrong in worrying only about that, and that's the other part of my teaching, but okay. But here, I just wanted to show the difference of approach between a prognosis and an operational definition of, so we have a decision to make about treatment, and so we need a definition of frailty that tells us what the patient is going to do with that treatment. So what has popped up over the years in oncology? Well, this is, they call that the Balducci criteria, and unfortunately, it's a definition that has had, I think, much more success than it deserves. And I'm a co-author on the paper, so sometimes they even call that the Balducci Extermann criteria, which made me even cringe even more. But we basically, at some point, we had to, tell oncologists a little bit what was a frail patient. So a lot of ECO thought a little bit about that and say, okay, well, above 85, usually people are frail. If they have dependence in ADL, usually it's things. If they have a geriatric syndrome, and if they have more than 3 or more major comorbidities, however you want to define them. Okay. So it's the advantage of being fairly simple. The oncologists are simple-minded people. They want the, give me the thing that I can just apply type of thing. And so that's, a lot of people have tried to use that definition for studies, but we actually don't know if it truly defines a frail patient. It's a common sense approach that was thrown in a paper and got a life of its own. But I will not have a heart attack if you tell me that it's totally out of out of the wood. And actually, it's not 3 major comorbidities; it's at least 5. And Anyway, well, that's what's around in oncology. These are other definitions that I think are a little better placed. These are oncologists who decided, well, let me try to do a study for frail patients. So they decided, okay, let's take some criteria and see, how they define the population. Let's treat patients, see how they do, and go back to our criteria, see if we indeed did find the right patient. So EORTC did a study in lymphoma patients, and they used a creatinine clearance of less than 50, severe comorbidities, poor performance status, cardiac dysfunction, platelets less than 100, neutrophils less than 1.5. These 3 last criteria are chemotherapy related. The standard chemotherapy for lymphoma is CHOP, even in the elderly. And so they took basically patients who could not receive CHOP. That's how they defined their frailty criteria. And they gave them CVP. Which is cyclophosphamide, vincristine, and prednisone. That was one way of doing criteria. Another one is a study by Monfardini again in lymphoma. And they said, okay, we'll consider frail somebody above 80 or somebody above 70 with a CRSG grade 3 comorbidity. There is a 3 that was left out. So it's more or less either 3 comorbidities grade 3 or 1 comorbidity grade 4. Dependence in ADL and 1 or more geriatric syndromes. And they did a study in that patient population. I'll give you the results of the studies later during the talk. So finally, I think, we may not know yet the definition, but there is a basic agreement both in oncology and geriatrics, that you have 3 categories of elderly. You have the healthy elderly who is just going to keep going on. You have the vulnerable that looks healthy but is at increased risk of complication or dying in the next few years because it's a hidden vulnerability. They look good but they have that dependence in ADL or anything like that. That's a harbinger of them crashing. And then you have the frail patient. And in oncology, this is really where the problem is. The frail patient is usually fairly obviously frail. The healthy patients, we don't run into trouble. But where we run into trouble is the person we think we could tolerate treatment and paf, they crash. Okay. So how do you identify that? That's really where the challenge is. So here is a frail dog for a change. And we come to the next definition. Since oncologists are trying to take an operational approach to the definition of frailty, how do we operationalize the definition of vulnerability and frailty in cancer care? Well, an option is to start by screening for geriatric problems. Say, we may reduce the group of vulnerable patients, or we may identify the group of vulnerable patients by screening. So they look healthy, but all of a sudden the screening is going to show things. So we do a screening, and if they screen positive, we either have a multidisciplinary team here that we have assessed them, or we refer them for geriatric consultations. And if the oncologists tell you that a geriatric assessment takes too long, tell them that this is BS. Okay, because they are going to take 2 weeks to do a PET scan, to repeat a biopsy, to place a port, to do a mega scan for their cardiac function. You have the time to do a geriatric assessment in 2 weeks. I mean, so just send them back to them. Yes, that's a no excuse in an outpatient setting. And so we've been working in oncology to adapt screening instruments. One of them is to take the VES 13 that we all know. And Supi Mohile did that. She took prostate cancer patients, 70 and older, and 50% of them had a VES 13 at 3 or more. They did a geriatric assessment by a geriatric team, and they found that 60% of these patients had 2 problems or more on a comprehensive geriatric assessment, which translated into a sensitivity of 72% and a specificity of 85%. So, you know, not quite as sensitive as you would like, but it could be a screening option. Another test that has been tried in oncology is the triage risk screening tool. This was developed by geriatric nurses for emergency room care. It's the work of Mion in Canada. And there is also an American equivalent developed by Mike Kusker. It was a set of 6 questions. And so they took that version, that Flemish version, because it's a Belgian group that did it. And they found that 71% of the patients had scored out positive on at least one item. And 51% of the patients had a positive finding on a comprehensive geriatric assessment. So if you take the cutoff of 1, which is less than the one that was used by Mion in the emergency setting, sensitivity is, sorry, it's a French slide that I mistakenly put. Sensitivity is 92.9%, positive predictive value 67.7%, and positive negative predictive value 87.5%. So, you know, if you're thinking screening, negative predictive value of 87 is not too bad. You know, like, of course, you have 100%, but, you know, if you want a quick test, that might be used. Okay. What else? Janine Overcash in Tampa did simply ask a question and say, well, instead of administering the complete scales, could we administer a shortened version of the scales as screening? So she did some mathematical deduction and found that 3 ADL questions, 4 IADL questions, 4 MMS questions, and 4 GDS questions Finally, there is the total empirical approach, which is the Senior Adult Program 2 screening questionnaires. That while Janine was doing her very sophisticated mathematical approach, our clinical nursing team had other ideas. So it's interesting when you are in charge of the research of a program and you have 2 pools of people who are trying to do 2 completely different approaches. So I told them, okay, go ahead, design a questionnaire. So they first took the LAX questionnaire, the yield questionnaire. patients, 2 of them were totally negative, all the others had something positive. If we take out comorbidity and the self-rated health polypharmacy items, just to make sure that we are not ceiling effect from comorbidity, actually we have a sensitivity of 91%, specificity of 44%, and again, positive predictive values of 80%. The same warning applies to negative predictive values. Since we only had 2 negative patients, you don't have a very good denominator for negative predictive value. So again, a very decently performing short screening to send patients to the geriatrician or the team in our case. That's for the screening. You can also try to see if geriatric tools will predict the outcome of cancer patients. And this is a study by Riccardo Odizio in Great Britain, where various surgeons did put 600 patients on a study of doing geriatric assessment. So you can convince surgeons to do geriatric assessment. And they found, they looked at the 30 days morbidity, and they found that geriatric variables, various geriatric variables, were indeed associated with 30 days comorbidity, complications. And very interestingly, the ASA score, the anesthesiologist's risk of operative complications, is absolutely non-predictive of 30 days morbidity. Yeah, and they did the POSSUM and PPOSSUM, which are the English versions of the ASA scores. It didn't work either. So, and this is a sample, and it's very representative of what we have found over the last 10 years. You take geriatric instruments, you apply them to oncology patients, they are predictive beyond the classic oncology predictors. So you definitely gain prognostic information by doing a geriatric assessment. And you can see that depending on the number of altered variables on a geriatric assessment, you had an increased risk of complications. So it's linear. On top of that, it's scalable. Okay, option B, pick up a definition of frailty and try to see how it goes for cancer patients. And that's what Souberan and Monfardini have been doing. It's a bottom-up approach. You take the bottom of the basket of cancer patients, you give them a gentle treatment, you see what happens. So URTC, did they target by geriatric criteria, right group by this very simple oncology criteria? They actually did a fairly heavy group. 40% were PS3 or 4, half of them ADL dependent, 81% of IADL dependent, 78% were screening positive for depression, 37.5% were screening positive for dementia. So it was indeed a frail group of patients. And it is above the average we saw in our clinics, as I showed you earlier. What happened? Okay, 27 evaluable. Actually, you had a 40% response rate, which is not that bad for a CVP and a high-grade lymphoma, I have to say. They also had an interesting thing is that, yes, they had to stop treatment for some toxicities, but they had 3 patients who died just of their general condition. These were frail patients. They just died. Okay. Which, of course, is not helping with the interpretation of the study. But despite these very frail patients, they happened to have a median progression-free survival of 8.7 months and a median overall survival of 10.1 months, with 40% of their patients alive 1 year later. So controlling the lymphoma, even in these very frail patients, seems to provide them some help. Option C is to go back to your chart reviews, cohort, population, and things like that, and see what happens. So this is a series from Rochester, New York, and they looked at patients who had febrile neutropenia or infections after their chemo, and they looked at the number of major comorbidities they had. And I mean, it's not a total surprise, but it's, you know, you can see the graph. It's fairly impressive. If you have a large number of major comorbidities, it's a bad thing to get febrile neutropenia. So it's an argument to give, for example, Neulasta to these patients upfront. You know, you really want to prevent that febrile neutropenia. What about cognitively impaired patients? Okay. Here, I think we have a very interesting piece of data. If you look at the SIA registry, they get adjuvant chemotherapy for colon cancer at 20% the rate of other patients. Okay. No, we just went back to our database and looked at our initial screening and look at the mini-mental status score. Some of them had a diagnosis of dementia, others were just...
You know, because the interesting thing with Alzheimer's patients
right.
is they tend to be healthy otherwise. They don't have
right.
a lot of
reason. And then in the frail patient, I think you go the bottom up. You do supportive care versus a low-dose treatment to see if you improve. People have done that, for example, in small cell lung cancer or in non-small cell lung cancer. They said, okay, 70 and older, let's try supportive care versus vinorelbine. Okay, vinorelbine does better. Oh, great. Okay, so now let's do vinorelbine versus gemcitabine plus vinorelbine. Okay, well, here the results are a bit more fuzzy, but okay, another frail individual. So now I want to finish my talk with asking, can geriatrics compete in oncology? Okay, and honestly, I think the geriatricians often have a problem of self-image here. They see oncology as big science with big guns, and you know, what are we doing with our geriatric assessment and our soft methods? Well, more than you can believe. Okay, here is an Indonesian study to whet your appetite. Randomized study in a general hospital, extremely simple. You have 87 patients with stage 3 hepatocellular carcinoma, aged more than 65 years old, and you hospitalize them either in medicine or in geriatrics. Okay, simple enough as a design? Fine. But here we go. What happens? Well, hospitalization duration is about the same. The geriatrics recover on average 3 ADLs, whereas the medicine ones only 1 ADL. The pain score gets down to 3.8 instead of 4.7. So here again, significant. You gain better pain control if you are hospitalized in geriatrics. And so no surprise, the quality of life is better for the patients who come out of the geriatric ward with their cancer.
Now, did they get interventions for their cancer as well as being hospitalized on the geriatric service?
At the time, for hepatocellular carcinoma, there was not a whole lot of interventions for stage 3 hepatocellular cancer. That's before the sorafenib era. So basically, you kind of renourish them. You can them adriamycin if they are in good shape, which I doubt 65 years old in Indonesia, as we are getting very much. You might do chemoembolization, possibly, but I think basically it was trying to pump them back up.
What was the reason for the hospitalization? That they were unable to care for themselves? That they were ADL dependent, or were they just...
Right, like some acute decompensation, workup, and things like that. It was a conference poster, so I'm still waiting for the article to be published with full details. But yeah.
Oh, sorry. How did the wards differ? Were they only the practitioners providing the care, or there were?
Yeah, you had a geriatrician in the geriatric ward, and otherwise internal medicine people in the medicine ward. And the geriatrician was trying to show actually the internal medicine people that what geriatrics could bring to their patients.
There's probably a lot of nursing intervention.
Yeah, probably. Yeah, right. The poster, I don't remember how much detail the poster were giving on the intervention. As I said, I'm eagerly waiting for the article. I'm actually write Cyrano telling him, hey, publish! Yeah, right, absolutely. Okay, this is the VA study. R.T. Rao looked at the cancer patients, very few cancer patients. You know, the VA study was like 1,000 or 1,200 patients. That was the JMU GMC, the one by Harvey Cohen. So it's kind of surprising, actually. I'm really surprised that they have so few cancer patients in that VA study, because you would expect a... Right. Yeah. Yeah. GMU was the inpatient and GMC was the outpatient thing, and it was.
They didn't take the cancer patients, right?
Oh, maybe the units didn't take the cancer patients. That could be the case. Yes, indeed. Although the right, and so the GMU was having better pain control at discharge. Otherwise, no differences at all. The entire study was globally negative, but. I can't put too much weight on that one because it's such a small number. I mean, 99 patients for a 4-arm study, for a 2x2 study, very, very low power. But to be honest, I cite it because I want to cite all the evidence. Now, this is much more interesting. This is Ruth McCorkle's study that she did. She's in Yale, but I think she did that before being in Yale. She was in Princeton. She did that when she was in Princeton. And basically, she took cancer patients 60 and older, undergoing surgery for their cancer, all comers. And these patients were randomized at discharge between 1 month of intervention by nurse practitioners or nothing. Enfin, usual surgical care, post-surgical care. And the intervention was a once a week home visit and a phone call once a week. And they were doing the geriatric stuff, assessments, interventions of various kinds that you would do as a geriatric. She has a whole table of what she did in the article. And interestingly enough, at the end of the study, there is a survival advantage for the group that had the geriatric intervention. And if you look in details for the patients with early stage cancer, you do not see a whole lot of survival advantage, whereas the one with advanced stage, you actually do see 27% 2-year survival advantage in absolute terms. So was it due to population selection? They looked at that, and actually they had more patients with advanced stage in the intervention group than the control group. So that's not what bias is. If anything, it would play against the intervention. So so they did not do a whole detailed evaluation. It was kind of an unexpected result. They were expecting functionality to be better, quality of life, but survival that size, no, they were not expecting that. How could we explain that? I mean, are these results real? Okay, because if you look at the meta-analysis that STGEC did in '93, well, there is a 14% relative improvement in survival over a follow-up of 1 to 3 years with CGA in geriatric patients. He saw, however, in his meta-analysis that the CGA was more effective, geriatric intervention was more effective in patients with acute situations like CHF, for example. You were preventing rehospitalizations, maintaining people more functional outside. And so it might be compatible with a higher effect in cancer patients. The other hypothesis you can do is, if I take a schematic view of functional reserve coming down to death, surgery is an acute event that happens here. And after that acute event, but before that, you could have the disease that might already affect a little bit the functional reserve. But after that acute event, 3 scenarios can happen. Scenario number 1 is they bounce back to baseline and they keep going on the same curve. Number 2, they don't recover completely and they keep going to a parallel curve that is lower because there is permanent damage from the surgery and circumstances around. And then finally, you have a third curve. Well, unfortunately, surgery is your decompensating event and the patient just crashes. So
you don't have them going back up after the surgery.
Right, so they simply...
You would think that there's certain surgeries that they're going to, that you won't continue on that same curve, right? I mean, if the surgery, say you have a bowel obstruction.
Right.
So you relieve the bowel obstruction, shouldn't occur.
Yeah, well, they will go higher because your bowel put you here, and so you would bounce back to your baseline aging curve. Yeah, that's why I put the little disease shoulder. Yeah, and so, but you would not go above your decline that started with your basic aging. Yeah, unless we find the wonderful cure of Jouvence, fountain of Jouvence. So what I would hypothesize is McCorkle's intervention may have allowed actually more patients to go back to level B or A, and hence delaying their death. That's one possible mechanism by which she improved survival. The second mechanism by which she might have improved survival is if you have a better functional recovery, and if you have a patient who has less anxiety because they understand their tumor better, somebody took the time of explaining them things, then they will get a better chemo. And if you get a better chemo, you get a better survival. That's the prime reason we do adjuvant chemotherapy, after all. And for example, in colon cancer, if you give the top chemo, which is FOLFOX and bevacizumab, you get a median survival of 22 months. If you give FOLFOX without bevacizumab, your median survival is 16 months. So let's say if they have cardiovascular problems, that would, thank you, that would limit your use of bevacizumab, you lose 6 months of survival just right here. And then if the patient is in kind of a not so good a condition, you say, well, oxaliplatin, no, they're not going to take oxaliplatin. So you give 5-FU continuous infusion, which is an effective treatment, but it will only give you a 14-month median survival. So here you're already 12 months below the FOLFOX. So and that fits very well with, these two hypotheses fits very well with the fact that the difference was mostly in patients with advanced stage and not the one with early stage. So that's my hypothesis, and I'm trying to design a study to address that. So what should we do? Well, we should define this decision threshold, as I said, operationalize things. We should refine our screening procedures so that we can really truly identify the patients who have the geriatric problems. And then we really, just like Ruth McCorkle, have to develop geriatric interventions in this patient, because visibly, you know, if you reproduce these results, okay, and find this kind of curve with your geriatric intervention. If I have that with a chemo drug, I'm at a plenary session at ASCO. Okay, guaranteed, because it's treatment changing. So if you do that with a geriatric intervention, you should end up in the same place. So geriatrics is competitive in oncology, and you don't be shy about talking to oncologists. Okay, you have effective tools. They don't look like gadgets, but they are effective. Okay. Okay, so in conclusion, I'd just like to remind you that cancer is the second most frequent disease in the elderly, in path of becoming the first one as we treat cardiovascular diseases better. Oncologists do see and treat frail patients, so there is a role for the geriatrician in the oncology world. I think one of the most pressing questions right now is to define vulnerability and frailty in cancer patients. I will let you add in geriatric patients, probably. And finally, geriatricians have much to share with oncologists, and don't underestimate what you have to share. And I put a picture here of a geriatrician who really personifies that. His name is Gilles Albrand. He's in Lyon, France. And he interacts with an oncologist in the Centre Léon Bérard in Lyon. And they have a geriatric oncology program there. And he is the geriatrician probably that I know who has best managed to learn how to talk to oncologists. And one of the things that he says is that he says when a geriatrician talks to oncology, he has to have cookies. And the cookies are data. Okay. Oncologists are very data-oriented people. They love the study that says this and that. Well, you have plenty of studies in geriatrics. So instead of saying, you know, I think this patient is really frail, say, well, you know, according to so-and-so, that means frailty. So, okay, here we are. And that study demonstrated that, yeah, they crash. So if you talk to oncologists like that, they're going to respect you. Another way that you get respected as a geriatrician is if you show at the tumor board, and the oncologists are scratching their head about what they should do with that 80-year-old patient. And you are asking the couple of key questions that are going to unwind the case. Do they love that? You know, unfortunately, Gilles does not speak English that well. He's a brilliant speaker in French, but in English, he still has some progress to make. But if not, I would clearly suggest you invite him. But if you speak French, talk to Gilles. Or if you go to the SIOG conference, the International Society of Geriatric Oncology, you'll meet Gilles. He's around usually. Okay. I'm done. Any questions?
I'm a physician over in our geriatric rehabilitation unit.
Mm-hmm.
We frequently are asked to take patients who have a cancer, and the oncologist says, say, take them and do rehab and get them stronger, then we'll give chemo.
Right.
But, you know, a lot of times they're weak because they have cancer, not because we need to have our physical therapist work with them for 3 weeks, right? Has anybody ever looked at that?
Right. I think the rehabilitation part, there have been things done with respiratory therapy for lung cancer or head and neck patients prior to surgery. And clearly, with giving good respiratory therapy, you improve their prognosis, surgical prognosis.
If you're going to do a lung resection or something.
Yeah, if they're going to do lung resection or even a major surgery,
Right.
you know, you prep them from a respiratory point of view, you definitely improve prognosis. Same thing for head and neck cancer surgery. If you re-nourish them prior to surgery, you get a better outcome of surgery. Right. The other way around is a good question. After surgery, once they are in the, you know, if you do rehab, my empirical experience is yes, it's worth to do 2 weeks of rehab before doing chemo because chemo doesn't work in one day. I mean, it takes a while, and before you get better, you get a little worse from the side effects of the chemo. So usually, an average oncologist would like to see them at an ECOG performance status of 2.
But I think if somebody has a cancer that's made them weak and frail,
right.
then you know having the physical therapist walk them
right.
2 hours a day is not going to make them
right.
less frail.
Okay, so typically what I do is assessing a few things. Number one, I ask the patient how they were doing 3 months ago. Because you can have 2 things, indeed. If they were doing fine, and now they are in trouble, that's probably the cancer. And if you treat the cancer, you'll get them back to baseline pretty easily. The other part is the patient who already had some impairments before, hasn't changed majorly with their cancer, and so you can expect that whatever you can rehab will be good for their cancer treatment because it's probably not the cancer making them sick. So that's my first screening question.
Right.
The other one, I don't know, because Ruth McCorkle's study are challenging. It looks like helping them recover from their surgery
Well, yeah, that's
better.
a different thing.
Right, that might help.
And that's probably just good case management.
Right. Absolutely, maybe. I didn't show that, and I don't know how much it's related to not, but they only had, during that month, 1 death in the intervention arm, 8 deaths in the control arm. Is it because they did a good job preventing bad complications? Sure.
Right.
Yeah. Yeah.
On that, yeah, case management is you
right.
intervene early.
Right.
But to get a patient who has, we even had referrals from, adeno of unknown primary.
Right.
And the oncologist will say, well, their performance status is so bad that I wouldn't give them chemo.
Right.
We give them 2 weeks of rehab, and then we'll think about it.
That's relatively unlikely. Yes,
Right.
I agree. Yeah.
Because I don't think they're going to be able to participate in the rehab. If they're
right. That's what a lot of oncologists don't realize is for a good rehab they need to be able to exercise 2 hours a day, and I tell that to my.
But as far as you know, there's no literature on that.
Right.
You haven't seen any literature that whether
right.
physical rehabilitation can prepare a person for chemo.
I can't think of an article right now. I've seen lots of exercise studies, like breast cancer patients, exercise program versus no exercise. But exercise is not the same thing as rehabilitation.
Right.
And indeed, I think there is a lot to do in rehabilitation. Would it help? I mean, the only thing I know is respiratory therapy. I can think of right now is respiratory therapy prior to surgery.
Now, if they're, if they have a poor performance status because they haven't been eating well, because
right.
they haven't been getting the right food, and
right.
maybe they just need better medical management for 2 weeks.
That's right.
And that probably does need to be done in an
right.
interdisciplinary setting, and similar to what you would see in a rehab setting.
Absolutely, yeah, right. But I don't send my patients to a rehab center usually before I treat them. If they had surgery and they need recovery, that's a different story. But when I see them initially, usually it's a multidisciplinary approach. And right, I mean, rehab is not what they need at that time. They may need that later. Mm-hmm. They may need that to prevent further falls, or they may need that with a specific rehab objective in place, but not as a general condition enhancer. Usually you get better results by making sure they have a caregiver,
mm-hmm.
Making sure
they understand their medication.
They understand their medication, review the medication, / things, give them meals on wheels.
Right.
A lot of people are kind of shy to tell them they can't prepare their meals anymore. And say, I don't have much appetite, and you kind of dig a little bit, and is that because they just don't have the energy to go shopping. So no food at home. Yeah, well, there's nothing to eat. That's it. I mean, it's one way of starving. So yeah,
Thank you.
you're welcome.
Yeah, I teach the geriatric assessment to the medical students and residents, so I appreciate this
Okay,
information.
you're welcome. Yeah.
And so what you use in the clinic is what the nurses developed?
Oh yeah, let me show you the let me show you the
I-
SOP2's questionnaire.
You also find so many different
Okay.
things that you can do in the geriatric assessment.
Right. Okay, let me. Oh, do you have an internet connection here?
Yes, we should.
I don't think that's hooked up.
It's not.
It's not hooked up. Okay, so let me just. It's on my computer, but I can load it on my key.
So, I don't have access.
No, but that's fine. I have it on my computer, so I'll just transfer it with the USB key.
Yeah, but it's not hooked up.
It's not hooked up, yeah. Okay, so here is our screening questionnaire. So it's a very simple set of yes or no questions. So on one side of the page, patient fill the things, check whatever their answer is. And then on the other side, they have those first screening questions and the mental status. So, you know, if it was necessary, is there someone who could help take care of you? Yes, no. Do you feel the two question depression screen? Do you feel sad more days than not? Lose less interest? Of course, you always have the little funny bone of the person who circles sex in big letters. But it's also actually a nice, you know, way of talking sexuality. If they have a concern, it makes it an allowed topic. Yeah. Have you lost interest in things you do? Okay, yeah. Question 4. We kind of put that, the first version, we said, okay, well, why not put a quality of life question? It's kind of a hunch, more than curiosity, more than any evidence. Actually, it proved to be a great screening question. Because if they rate their quality of life as less than 8, you know, something is annoying them in their life. I mean, it can be depression, sure, but it can be that they have pains, or you know, their spouse has Alzheimer's, or whatever, you know. And so it's always worth to send the social worker when they rate a low quality of life, because you are going to dig out a whole bunch of stuff. Present health also, if they rate their health poor to excellent, self-rated health. Then we continue with kind of a shortened version of Katz and Lawton's ADL-IADL, because some of the impairments were very infrequent in our population, so we decided that for a screening test we could drop them, make it a bit shorter. And we asked the fall questions. Have you tripped or fallen in the last year?
Yeah.
Then we continue with 3 nutritional questions. Weight loss, decreased appetite, change of types of food. Any yes triggers a dietitian. Are you able to pay for your medications? Big social work question. And do you feel you are sleeping well? Because it screens for all sorts of things. I learned that from at a geriatric conference, actually. And here is the 3 questions of the mini mental status. 10 out of 12 is good. Below is do more screening. And then the rest is optional. How many medication are you taking? If they have 3 or more, we do a careful review of the medications. And then we can, if we, let's say they screen positive on the 2-item depression screen, the social work is going to do a GDS or a mini mental status and go further, say, okay, they need psychiatry referral or they need a neurocognitive evaluation, things like that. So fairly simple.
Simple. It's touching all the
Yeah, touching the base.
domains.
Right, touching all the domain.
What would be good is to have one for the acute patient.
I think one of the things is people don't believe how much is going to be helpful until they've tried it. And it's just like the questionnaires for integrating geriatric assessment questionnaires in studies. People have a lot of resistance in cooperative group to that. But everybody who has done it says, yeah, sure, it's not a problem. if I have to accrue a patient in a trial and my research nurse is not there, I basically do it in between 2 patients. It's 15 minutes. So you can do geriatric instruments in a study setting. It's no big deal. So, and the patients don't mind. They are all happy to help, actually.
Thank you.
Okay.